Good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec O'Dare. I'm the Managing Director for UCCT. This evening's session is called A Clinical Tool for Continence Assessment, the Colley model. And we have the original author of that model, Wendy Colley, OBE no less, who's a freelance writer and continence care advocate with us this evening, along with Sharon Eustice, who's a nurse consultant, bladder and bowel specialist service partnership at NHS Foundation Trust. The event this evening is supported by the AHPMA, which is the Absorbent Hygiene Product Manufacturers Association. You probably see that I've just looked down at my notes just to make sure I got that right. They represent lots of companies that actually produce products in that sector. So thank you very much to the AHPMA and all of your members for supporting this evening's session. Wendy, Sharon, are you with me? Are you okay?
Yes, thank you, Alec.
Brilliant. Okay, so just a little bit of housekeeping as always. Most of you have joined us before, but I'll say it again. You can see we're working from our homes this evening, so if there's any technical issues, do please bear with us. Links to certificates will be available at the end, and we'd like you to ask as many questions as you possibly can, because after the presentation we'll be coming back for a live Q&A. So let's try and make this as interactive as we possibly can. Copies of slides, people always ask for copies of slides. They'll be available after the presentation as well. I think that's it from me, so I'm going to hand over to you, lovely ladies, and to go through the presentation, and I'll be back after that to chair the Q&A. So good luck, and I look forward to catching up with you shortly.
Thank you, Alec. I'm going to start us off. So good evening, everyone, and thank you for joining. So the learning objectives for this evening are going to be around continence assessment, which I'll lead us through just to set the scene. And then Wendy will take us through why the Colley model was developed, the aim of that model, and also will tell us how to use the model effectively and introduce us to two examples of patient assessment through the case studies of Mary and Margaret, and also where to find this free access to this resource, which will come back to me for me to describe that to you, and how to implement the Colley model, which I will give you some examples of how I'm doing that in my local practice across Cornwall and the Isles of Scilly. So just to sort of kick us off in terms of continence assessment, now many of us will know lots of literature around continence assessment and how important it is, and that incontinence continues to be a prevalent condition, and it's staggering, the figures across the globe. Clinicians play a critical role in clinical assessment, and nurses are indeed at the forefront. Yet attention to incontinence can be low, although there's been a consistent drive to boost up interest, passion and dignity for sufferers in an often neglected area of healthcare. For example, inpatient audits of people with stroke showed that 41% of them had urinary incontinence, but only half of them had a continence management plan created or implemented. There continues to be a belief that urinary incontinence is a normal part of aging, and it might be less distressing for older people, but we know it's not inevitable to have incontinence as we get older. Aging is a risk factor, but it's really important that we do our very best. If a patient says that a symptom is bothersome, then it's important and requires further yet sensitive questioning. And a symptom is important if it can yield more information on what is the underlying problem. So there is a fair stack of evidence out there to guide us. One of our challenges is implementing that evidence into practice. And urinary incontinence has a profound effect on the quality of life of older people in terms of their subjective health status, levels of depression, low mood, and need for care. And there are several long-term conditions that we're all caring for now, and environmental factors also increase the risk of urinary incontinence in older people. For example, NICE in 2015, and updated more recently most likely, provides guidance on quality measures, saying that we should have clinical assessments a fundamental part, for example, in assessing women. Other organisations like the International Continence Society and the Association for Continence Advice and the Royal College of Nursing, and there are more, and interest groups who are striving to improve care and they have a dedicated focus to bladder and bowel health. Population surveys tell us that incontinence is staggeringly high. The prevalence range of urinary incontinence across the literature is from 5% to 70%, with the majority of research indicating a prevalence of any incontinence in the range of 25 to 45%. But with advancing age, the prevalence of the disease rises, and more than 40% of women over the age of 70 can be affected. And the prevalence of the disease is significantly higher among the elder and also those who are in nursing homes. There's an incredible talent across the NHS and other healthcare systems. Yet nurses, for example, may not have enough knowledge. Excellent healthcare delivery is underpinned by a skilled workforce. But what does that mean? What is a skilled workforce? Well, according to the leadership literature, we need a motivation for change, a shared vision, a capacity for change, but taking those first steps towards improvement and improving our skill. Now, there's some references in this slide that I'm showing you at the moment, and when you download a copy of this presentation, the slides are already in there. So I'm going to hand you over now to Wendy, who will kindly take us step by step through the model. Thank you, Wendy. Over to you.
Thank you, Sharon and Alec. I'm Wendy Colley, and I'm very grateful to have the opportunity to present this resource to you today. A continence assessment is a bit like a jigsaw. The assessment gathers many pieces of information, and the aim is to complete the jigsaw. This may be after several attempts or reassessments, and the final piece is in place when the patient achieves the best possible outcome. This may be a cure, an improvement in the symptoms, or a better management regime. In the late 1980s, the specialty of continence care was new and evolving. As a continence advisor, I found that nurses were diligently completing the assessment form, but moving straight on to managing the leakage. Something was needed to help the assessing nurses identify the cause and contributing factors for the incontinence and formulate a treatment plan. So I developed the Colley model. It was first published in 1991 and has been updated over the years with changes in terminology and processes, but the basics have remained the same. The terminology and definitions used here are those recognised by the International Continence Society. The latest update of the Colley model was launched online in October 2020, having been suggested by a continence specialist who felt a practical tool was needed in support of published documents, such as the 2018 Excellence in Continence Care. The overall aim of the model is to assist those assessing an adult with urinary leakage to identify the underlying cause or causes of the symptoms, recognise any contributing factors, and implement positive treatment or referral. During the last 2 years, staff from many continence services have been redeployed to maintain essential services. Bladder and bowel services have had to continue as best they could. This was a specialty under pressure before the pandemic, and even more so now. Once again, initial continence assessment is falling on the shoulders of those least equipped to carry it out. The model can be used by those with very little knowledge of this specialty as a tool to learn more about bladder symptoms, or as an aid memoir by those more experienced. It can be used by nurses, physiotherapists, occupational therapists, GPs, and students training in these professions. It can be used in any care setting, in hospital, the patient's own home, in residential and nursing homes, and in GP practices. The model is a colour-coded pathway. Online, this is a scrolling script, which I will demonstrate as we work through it. Red flags highlight symptoms which could be due to underlying serious pathology. For each type of incontinence, there are also contributing factors listed and suggested treatment. This resource is freely available on a website developed and maintained by AHPMA, to whom I and many others are very grateful. We will tell you where to find this at the end of the presentation. You will also find a printable copy of the model here. On the website, you will find further information and resources to support the assessment process. Many of you will have access to the assessment form used in your organisation, but one is available here if required. Colour coding works as follows. The main assessment considerations are in blue boxes, which are also linked to explanatory notes. Yellow coloured boxes suggest discussion, referral and treatment. The model recognises 4 types of incontinence. Responses in the orange coloured boxes may indicate stress urinary incontinence. Responses in the sand coloured boxes may indicate urgency urinary incontinence. Responses in the green boxes may indicate overflow urinary incontinence. And responses in the pink coloured boxes may indicate functional urinary incontinence. Responses not specific to any one cause of incontinence are in uncoloured or white boxes. Boxes with more than one colour could indicate a symptom synonymous with more than one type of incontinence or indicate an action required. This image is side 1 of the printable A4 sized copy. I'm showing this image for you to see the model on one page. Don't try to read this, as I know it's too small to read. The blue boxes form the basis of the assessment. The first section includes information gathering, screening and examination, also assessing for stress incontinence, the likely responses being in the orange coloured boxes. If no other symptoms are identified, then there is no need to continue further through the model. If the assessor has identified symptoms not associated with stress incontinence, such as urinary frequency and urgency, then the assessment continues through the next section, assessing for urgency incontinence. Responses in the sand-coloured boxes are usually associated with urgency incontinence. If the assessor has identified symptoms falling into the green-coloured boxes, such as voiding difficulties, then the assessment continues to identify whether the patient may be experiencing a voiding difficulty due to bladder outlet obstruction or an underactive bladder with the symptom of overflow incontinence. Finally, if still in doubt or if the patient has functional issues, continue through the final section to identify if incontinence is due to the inability to respond appropriately to bladder signals, resulting in functional incontinence. These responses are in pink-coloured boxes. Likewise, this is side 2 of the printable copy. This copy is intended to be double-sided, and when printed, you will find this side is inverted. It's meant to be like this, so when you flip the sheet over, the sequence of each type of incontinence is followed. Contributing factors and treatment for each type of incontinence are listed here. Red flags are mentioned too, alerting the assessor to the importance of symptoms the red flags relate to. I would recommend that you print a copy off the website for referral. I will now explain how to use the pathway. I will also be describing 2 examples of patient assessment as we progress. You will notice that the model is a scrolling resource rather than arranged in columns as it is on the printed version. The content is the same. Each blue box has a link to explanatory notes, and it's very important that these are accessed and read. Blue box 1 is all about taking a history, but the notes do state that if indicated, before taking a history, address any functional, mobility and dexterity issues which could contribute to or even cause incontinence. Include in this environmental issues and accessibility to the toilet. The history will include the onset of the symptoms, medical history, including any surgical, urological or gynecological history, medication, urine leakage, and a question about how the symptoms affect the quality of life. These are examples and not a comprehensive list. Next, the urine is tested. Please read the notes for more information with the link for this blue box. Red flags refer to blood in the urine in the absence of infection, which tells you to investigate following local and national guidelines. Also, an untreated urinary tract infection may lead to sepsis. If there is a history of recurrent UTI, ensure a bladder scan is carried out. Next, ask the patient to complete a bladder diary for a minimum of 3 consecutive days. An example of a bladder diary is on the website, as well as a frequency volume chart and micturition chart. Select the most appropriate for the patient's functional ability. From the bladder diary, you can collate valuable information, such as daytime frequency, nocturia, fluid intake and type, and number of incontinent episodes, for example. The red flag here alerts the assessor that urinary frequency and/or urgency can occur in women as a symptom of ovarian cancer. There is a link to further NHS information from the explanatory notes for boxes 3 and 4. I promised we would look at a couple of patient examples. Briefly, the first patient is 71-year-old Mary. She complains of urine leakage over the past 4 months or so, on exertion and quite severe leakage at times. She started to use pads. There is no history of previous bladder symptoms. Mary is fully mobile. She has no significant past surgical, urological or gynecological history. Her medical history records hypertension for several years. A few months ago, her medication was changed by her GP to doxazocin for high blood pressure. Her urinalysis showed no abnormality. Mary completed a bladder diary which showed urinary frequency of 6 to 7 voids in 24 hours, including nocturia ×1. The largest volume voided was 470 mils. Fluid intake was around 2 litres in 24 hours. This valuable information from the bladder diary suggests that Mary has what is considered a normal voiding pattern, and these responses fall into the orange box. You would also note that her fluid intake is good. The next questions relate to urgency and bedwetting. Urgency is the complaint of a sudden compelling desire to pass urine, which is difficult to defer. Undue urgency is not normal, but can be experienced by any of us if the desire to void has been deferred several times. For example, if we are stuck in a traffic jam for a long time. The red flag here again refers to the symptom of urgency being associated with ovarian cancer. Nocturnal enuresis is the complaint of involuntary voiding that occurs during the main sleep period. Urgency and or bedwetting would not usually be a symptom of stress incontinence. Therefore, no responses fall into the orange boxes. If the patient does complain of urgency and or bedwetting, then the responses fall into the sand and green coloured yes box. They could be symptoms of urgency incontinence or overflow incontinence. Therefore, the assessor continues to assess for stress incontinence, then carries on through the model to blue box number 9 and beyond. Our patient Mary has no complaints of urgency and no bedwetting. So responses are again in the orange boxes. The next step is that of observation or physical examination. Examination is carried out within the competencies of the assessor and include informed patient consent and the offer of a chaperone, in line with local and national guidelines. This may include vaginal examination in the female, including the assessment of the strength of the pelvic floor contraction, and rectal examination in the male patient to assess the size and texture of the prostate gland. Visual assessment of the abdomen and genitalia may reveal scars from previous surgery, a hernia, a significantly enlarged bladder or pelvic mass, prolapsed rectal mucosa, hemorrhoids, skin conditions, for example, psoriasis or lichen sclerosus, skin excoriation and damage and any discharge. In the female, pelvic organ prolapse may be visible, protruding from the vagina. The NICE 2019 guidelines state that women with urinary incontinence who have a symptomatic prolapse should be referred to a specialist. There may be visible leakage of urine from the urethra on cough. Atrophic vaginitis may be noted in postmenopausal women. Observe also for any leakage of urine from the vagina, which may indicate a fistula. In the male patient, observe for hydrocele, epispadias or hypospadias, which are congenital abnormality in which the urethra opens on the upper or underside of the penis. Record any abnormalities present. Looking at the boxes on this slide, in the female, visible leakage from the urethra on cough could indicate stress incontinence, but could occur in other types of incontinence, which is why the box is only half coloured orange. In the male patient, recent prostate surgery should alert the assessor to consider stress, urgency, and overflow incontinence. Measuring any urine which remains in the bladder after voiding is an invaluable aid to diagnosis. If the assessor has this option available, which means access to a portable bladder scan device, and has been trained to undertake this procedure, it can be done here. Otherwise, this test can be considered again under blue boxes 11 and 12. However, if there is an obvious enlarged bladder, the patient must be referred for further advice and a bladder scan. Back to our patient. On examining Mary, there were no abnormalities detected. She did, however, leak urine when asked to cough. Therefore, another response which could indicate stress incontinence. A bladder scan indicated that she was fully emptying her bladder. Constipation can be a major contributor to bladder symptoms, but is not specific to any one type of incontinence, unless the patient has fecal loading or impaction, when it can cause symptoms of overflow incontinence, which explains the half green and half white yes box. Constipation is the complaint that bowel movements are infrequent and or incomplete, and or there is need for frequent straining or manual assistance to defecate. The close proximity of the lower bowel and urethra mean that pressure from the bowel can obstruct voiding and prevent bladder emptying. Also, regular prolonged straining to defecate can weaken the pelvic floor muscles. Therefore, bowel care is very important, both in preventing bladder symptoms and to ensure treatment, such as pelvic floor muscle exercises, is as effective as possible. We then need to ask about urine leakage. Does the patient experience involuntary loss of urine on effort or physical exertion, including sporting activities or on sneezing or coughing? A yes response suggests stress incontinence. Mary said she didn't suffer from constipation. Her bowels are regular with diet. Yes, Mary leaks urine on effort or exertion. At the end of each type of incontinence, there are 3 starred boxes. The first gives an overview of that type of incontinence. The second lists possible contributing factors, and the third suggests treatment, as well as improving any contributing factors. By clicking on the starred orange-coloured boxes, the assessor can access the information with regards to stress incontinence. So what about our patient Mary? Her symptoms do point towards stress incontinence, but there is a piece of the jigsaw missing. Why did her leakage only start a few months ago? If we look back to our history taking, we see that her medication was changed for her high blood pressure. She was prescribed an alpha blocker, a medication which relaxes smooth muscle. The smooth muscle in the walls of the arteries is relaxed, so reducing blood pressure. But there is smooth muscle at the bladder neck. The medication will relax that too. So this is the reason for Mary's leakage. The treatment for Mary was to refer her back to her GP for an alternative antihypertensive, then reassess her once her medication was changed, and teach her to carry out pelvic floor muscle exercises. Before we move on, let me introduce the second patient example. Without going back several slides, I will briefly explain Margaret's case. She is a 78-year-old married lady. She and her husband have 5 children, several grandchildren and great-grandchildren. So a large supportive family, many living in the same locality. Margaret is mobile but slightly frail. She has some arthritis, mostly affecting her knees, for which she takes paracetamol, as required for any pain. Urinary leakage has been getting worse gradually over the previous couple of years, and now she is wet most of the time. She experiences the urge to void, but is incontinent before she reaches the toilet. The toilet is upstairs. Once she reaches the toilet, she is often unable to pass any more urine. A commode was supplied for use downstairs by the district nurse, but has not helped in reducing the incontinence. At night, 2 of her daughters visit and pad her up with towels. In the morning, the towels are soaked and the daughters return to remove the bedding and towels to wash. Margaret uses small rectangular pads in the day, which are inadequate for her needs. Her bowels are regular, and on physical examination, there was no abnormality detected, but she did leak moderately when asked to cough. Margaret had recently been treated for a urinary tract infection. The responses in the first part of the model fell into the sand and green-coloured boxes, indicating that the assessment continues. The next part of the assessment was to determine whether Margaret has urgency incontinence or overflow incontinence. The symptoms of urgency and overflow incontinence can be very similar, but the underlying cause is very different. So the next section of the model is assessing for urgency incontinence and directing the assessor onwards if indicated. Box 9 is an opportunity to review the symptoms we have identified, such as frequency, urgency, nocturia, bedwetting, urinary tract infection, and perhaps stress incontinence. We need to ask how well the patient passes urine and if there are voiding symptoms, such as straining to void, slow stream, hesitancy, intermittent stream, and terminal dribble. Those with urgency incontinence would not usually experience these symptoms. Therefore, a no response would fall into the sand-coloured box. A yes response in the green box should alert the assessor to a possible voiding difficulty. We need to know if the patient feels as though they emptied the bladder completely after voiding. A yes response falls into the sand-coloured box. If the answer is no or don't know, this falls into the green box, perhaps indicating a voiding difficulty. If not done previously and a bladder scan device is available, measure any urine remaining in the bladder after voiding. If the bladder is emptying, then we are most likely looking at urgency incontinence as the underlying symptom. Residual urine volume will determine the next steps, and any significant residual urine will direct the assessor towards overflow incontinence and to continue through the next section of the model. The volumes of residual urine mentioned on this slide are for guidance only, and discussing any residual urine volume with the bladder and bowel service is strongly recommended. I'm going to hand over to Sharon now, who would perhaps comment a little bit more on bladder scan and residual urine. Over to you, Sharon.
Thank you, Wendy. It's a really good point because I'm blessed in my county where many of my clinical colleagues have access to bladder scans. We could do much better, but essentially have access to bladder scans. And bladder scanning has been a real boon to us being able to identify a post-void residual urine. However, the consensus on post-void residual urine is controversial, and there's not necessarily one threshold for all cases. And now thinking is around looking at bladder voiding efficiency, not just for an absolute volume that's left inside the bladder. So I would tend to always verify a finding of a post-void residual urine. I would use my suspicion to say I need to get that checked out by another portable scan or a kidney bladder ultrasound, or even an in-out catheterization, which actually has been superseded now by scanning. But a lot of the literature is saying, should we be using bladder voiding efficiency, where you have a voided volume divided by the total bladder capacity divided by 100. So what you get is a percentage of voiding efficiency. And that might be more valuable because what we're looking at is that bladder uniquely rather than an overall threshold. So it's really good food for thought, but scanning is vital. Oh, back to you, Wendy.
Thank you, Sharon. So we need to ask if the patient experiences involuntary loss of urine associated with urgency. If the answer is yes, then the symptoms are most likely due to urgency incontinence. If no, we continue the assessment. Here we have the starred boxes, this time sand-coloured, giving an overview of urgency incontinence, a list of factors which may be contributing to the symptom and suggested treatment or referral. You will notice another starred box, half orange and half sand-coloured, for mixed urinary incontinence. This is relevant if you have identified stress and urgency incontinence in the same patient. Click on any of the boxes for more information. Back to our patient Margaret, who answered that she didn't know if her bladder was fully emptying. At the time of her assessment, there wasn't a bladder scan device available. So, after carefully considering the possible risks, it was decided to carry out an in-out catheterization using a size 10 Charrier-Nelliton catheter. Margaret had 800 mils of urine in her bladder. So the model directs the assessor to continue into the next section with her assessment. Yes, this was a large volume, and now we're beginning to determine the cause of her symptoms. Time again to review the symptoms we have identified so far. The patient may have frequency, urgency, nocturia, bedwetting, urinary tract infection, and perhaps stress incontinence. Also obstructive symptoms during voiding. The patient may complain of a feeling of incomplete bladder emptying. If at any time there is a possibility of a full lower bowel with impacted feces, we must always exclude that as a cause of the symptoms by carrying out a digital rectal examination, if trained and competent to do so. Boxes 15 and 16 ask if the assessor suspects bladder outlet obstruction or underactive detrusor. We are now into specialist territory, and if they haven't already done so, the assessor should now liaise with the bladder and bowel service regarding further referral, unless they are competent to decide the next steps. Both underlying conditions give the same symptoms but are completely different. One caused by an obstruction to the outflow tract, the other due to the detrusor muscle not contracting to empty the bladder. So the treatment and management are different. Ask about the urine loss. The patient may experience involuntary leakage of urine with or without urgency and may complain of varying volumes lost. Leakage may be an intermittent dribble and the patient may be unaware of the leakage or the desire to void. A yes answer in the green box would point towards overflow incontinence. The starred green-coloured boxes give the assessor an overview of overflow incontinence, a list of factors which may be contributing to the symptom, and suggested treatment or referral. Red flags remind the assessor to ensure men are screened to exclude prostate cancer. Also, there is a risk of ascending infection if the bladder is not fully emptying. And acute urinary retention, the sudden inability to pass urine, resulting in abdominal pain and distress, which is a medical emergency. You will be unlikely to see this at a routine assessment, but be aware that this can occur. Let's review Margaret. Her symptoms indicated that she was experiencing overflow incontinence. The underlying cause could be bladder outlet obstruction, perhaps due to urethral stricture, which is less common in women than in men, but a female complaint too, or other obstructions such as caused by a bladder prolapse or constipation, or she has an underactive detrusor. Margaret said her bowels were regular and on examination there was no obvious prolapse. The catheter passed easily to drain the bladder when checking for residual urine, so perhaps excluding urethral stenosis or stricture. So did she have an underactive detrusor? Ideally, Margaret would be referred for further investigations via, I would suggest, the bladder and bowel service. Margaret declined any referral suggestion. So what could be done? There were 3 management options for her to consider. The first, to continue as she was with more suitable absorbent products and the risk of recurrent urinary tract infection. The second, to carry out intermittent self-catheterization. And the third, to have an indwelling catheter with the associated risks. It would be interesting to know which option you think Margaret chose. Well, she chose the second option and wanted to try ISC. She mastered the technique very well and found that she was dry between catheterizations. So no pads, no wet beds. She could go to family get-togethers and even have an extra cup of tea. and she had a reduced risk of UTI because she was emptying her bladder. She said that intermittent self-catheterization had given back that part of her life which she had lost. If the previous section of the model has left the assessor still unsure for the reason for the incontinence, or the patient has functional difficulties, then continue into the final section. On reviewing the symptoms so far, the patient may not have symptoms indicative of any bladder dysfunction. So we need to ask, is the patient unable to reach the toilet or voiding in an inappropriate place? Does the patient have severe learning or physical disabilities, dementia, confusion, acute illness or trauma? If the answer to either or both questions is yes, then we must begin to consider functional problems which need to be addressed. With functional incontinence, urine leakage is usually a full void. Please remember that someone with dementia or learning difficulties can also have other underlying treatable symptoms, such as a urinary tract infection or an enlarged prostate. We arrive at our final 3-starred boxes, this time pink-coloured boxes giving an overview of functional incontinence, a list of factors which may be contributing to the symptom and suggested treatment or referral. Red flags refer to what I mentioned on the last slide, that the assessor must look for underlying treatable conditions. Also be aware that new onset confusion could indicate sepsis. Ensure use of the NEWS 2 scoring system. If you have worked through the model and have not reached a reason for the incontinence, you will have gathered a lot of useful information during the assessment. Discuss this with the Bladder and Bowel service, who I'm sure will be very happy to help further. That's all from me now. Thank you for listening, and I will now hand over to Sharon to see if she has anything to add and to explore implementation of the model, and importantly, tell you where you can find this resource. Over to you, Sharon.
Thank you, Wendy. Thank you very much for taking us comprehensively through the model and applying it to 2 cases. I think that was really useful. So how to implement this very useful resource that Wendy has spent a long time working on, and it will help our decision making. So for us, it's to bring around excellent knowledge, good practices and positive attitude for urinary incontinence. But to do that, we need education, plus tools to facilitate our decision-making, such as the Colley model. What I have done locally with my teams, and we're starting on this journey, is how we can embed the model within and hyperlink it within our existing system platforms. So that's what we're working on at the moment. So working with we currently use Rio in Cornwall. So we're looking at how we can hyperlink it within the localized assessment tools. And any suggestions for improvement on the model obviously can go to Wendy via the website. In Cornwall, we have local educational delivery opportunities every couple of months. And so I will use that with my excellent colleagues as an opportunity to raise the profile of the model as a tool to support decision making. However, what we have to be mindful is the current climate. It's turbulent and we're all recovering from the COVID pandemic. And therefore, we're all dealing with long waits for care. According to the latest NHS and NHS improvement document that came out this month, there are 4 factors to help guide us. Increasing capacity, which is important for all of our services. So business case building, etc., making sure we have the right resources to match the need of our patients. Prioritizing good diagnosis and treatment plans, not just jumping into management with products. Transforming elective care, and we're part of a wider machine, and thus better information to support our patients. So how can you access the Colley model and have a look and check it out? Well, there's an easy website address to remember, which is www.uccct.org. continence assessment, all one word, .co.uk. The About tab explains about the model. You will find the names of the continence specialists who kindly contributed to the update under Who Are We, and the model, where to find the link to download it, and also to how to print it in A4 copy. Wendy explained that each blue box has a link to explanatory notes, and the notes are available from this tab. Resource downloads include a continence glossary, bladder diary, and other baseline charts, pelvic floor muscle exercises for both men and women, and bladder training. There are also links to continence organisations. If you don't have an assessment form, there is one to download. And if you have any comments or want further information, there are 2 email addresses on the website which you can use, and Wendy will monitor those mailboxes. Thank you so much for listening, and thank you to AHPMA for inviting Wendy and myself to be able to be with you this evening, and for all the team in the background who's helped this to happen. I'm going to hand you back now to Alec. Thank you very much.
Excuse me. Thank you, Sharon, and thank you, Wendy. A very interesting and informative presentation as ever. After listening to that, I actually feel quite privileged, Wendy, to have you with us after you've created it. Sharon's obviously a big fan of the model. I've got just a couple of questions I just want to ask you both myself. That just some things that I've been thinking of. The first thing is incontinence more prevalent in men or women, or is it even? Or is that data available? What's the split?
Wendy, shall I take that one?
What, Sharon? Thank you.
Essentially, the literature tells us it's more prevalent in women because of many different influencing factors: childbirth, menopause, anatomy. Men aren't excluded from the problem with incontinence. So essentially, it would probably be 3 to 5 out of 10 women and 1 to 2 out of 10 men. So essentially, both can experience urinary incontinence. And of course, we're only talking urinary incontinence, not necessarily bowel or fecal, but it is more prevalent in females. Okay.
Yeah, I guess that's why I asked the question, because there's a lot of factors talking about sort of prolapses and sort of childbirth and all the rest of it, and we've been having conversations about those sort of things in works just recently, actually. So it's I was guessing that it would probably be towards females. My next question: what about sort of is there? I may be simplifying things by asking this question, but is there a sort of an average age where where incontinence starts to become an issue, or is that? Yeah, I guess I'll just leave it there. Is there an average age for when incontinence starts to become a problem? And that's over to you both, I guess. And I don't know if you've got any stats for it, but maybe Wendy, do you know the answer to that?
Well, Sharon may know the stats, but I mean, it's a problem that affects all ages. You know, we have children can suffer from incontinence when we would hope that they would be in control of the bladder and bowel. And again, it goes through the life, but obviously with age, then the problems do increase. And as Sharon has said, you know, it's more prevalent in women than men. But I think with advancing age, then perhaps the numbers do get a little bit closer together. I don't know whether you want to add to that, Sharon.
I think you've got a very good point, Wendy, and certainly my caseload covers from the earliest age right through to the oldest age. And I would say it's a classless and an aging condition. So it can happen to, and I have a lot of children in my clinics, as do my colleagues across the country. But etiologically, there are factors that will probably increase women's risk around a certain time of life. And for men, after prostate surgery, for example, increases then. And of course, if you look at a cohort of people who have frailty, both men and women at a certain age, their propensity to incontinence is higher. So there are lots of different cohorts. So if you get someone with a spinal cord injury, a particular long-term condition, diabetes, multiple sclerosis, Parkinson's, it covers so many cohorts. And that's why my service and many other services, you know, it's almost, you know, the demand is huge. The demand is huge. So that's why it's really important that bladder and bowel services for children, young people and adults are resourced to enable the members of the public and different cohorts to get excellent care, get good diagnosis, good treatment, so we avoid pushing people into products where they don't need products.
Yeah. I guess just
interesting question though, Alec. Very interesting.
Yeah, I mean, just following on from that, then, are there, like there are in other specialist areas, then are there pediatric and young person bladder and bowel specialists, and then adult bladder and bowel specialists, or is it just one service? Because it sounds like as though, Sharon, you deal with the whole age range.
Yes, we do. In my county, we do. The challenge for our services for bladder and bowel is that we are a diverse group across the country and the countries of the UK, and probably globally. We'll have all different healthcare systems. What we need is less variability, much more consistency, but there will be, in my neighbouring counties, it's mainly the children's dedicated services and adult dedicated services, so two separate services, whereas mine is one. So it's varied. It's varied. And of course, the all-party parliamentary group and NHS England have driven up some really good documents to enable our commissioners to have a levelling up of all of our services across the country, because the people suffering with bladder and bowel problem deserve to have the best access to care.
Yeah, I totally agree. Wendy, question for you then. So you were a continence nurse. At what point did you come up with the Colley model, and what made you think that there was a pathway essentially that needed to be made, and when did you do it?
And it's a long time ago, Alec. It was I became a continence advisor in West Cumbria in 1987. And this was just as services were evolving. Not too many years before that, I think it was a push from the Department of Health, I believe, to try and recruit continence advisors or nurse specialists in each area, because there weren't such services. And it was soon after I realised that nurses were completing the assessment form. And as I explained, they were going straight on to managing the problem. There was something missing. They didn't seem to be able to interpret the symptoms and, come up with a diagnosis and a treatment. But of course, that was before we had a lot of education in the topic. It was a pretty new specialty, but then. So it was the about sort of late 1980s, beginning of 1990s that I developed the model, and it was first published in 1991. And it was used then to, we just used it to try and, encourage nurses to come to a diagnosis and to get treatment for the patient.
And has it evolved? Has it evolved since then, or is it the same? Is it the same model as back in 91?
It's the same principle. It has changed with terminology and over the years. It was, I did at one point work for a company, and it was available to customers then online for the nurses to use. But it's been updated over the years, several times, and it will be updated again as well.
Yeah, so there's a question that we've obviously had a load of questions that have come in, so we'll just get on to a couple of those. For those watching, as I say every time, keep the questions coming, because even if we don't get a chance to answer them this evening, we will actually reply to them. What happens is we'll get through as many as we can in the next 5 or so minutes. If we don't answer your question, we'll create a PDF, which will be available next to the slides and a copy of this video on our website for you to be able to download. There's probably a good time for me to ask this one of these questions that I can just see here that somebody sent in, which is it says it's for both. It was probably just following on from that little explanation of how you came up with the Colley model, Wendy, which is there a Colley model for children and young people, or is it the same model for everyone?
There isn't at the moment, and when I first started to develop the model, my service was a bit like Sharon's. I covered children and adults, the whole age group. And I thought I wanted to include children, but it was pretty obvious when I started doing this, that children they had different a set of problems. It didn't fall into the same, the same boxes as the adult problems. And over the years, I know that paediatric specialists have asked if there is a model available for children. I think it's the job of the paediatric specialist to do this. And I do know that June Rogers and Davina Richardson are working on a model for children. And hopefully, they do hope that it might be available this summer. And it's, they've been working on this for quite a long time, since, maybe the past 4 or 5 years, but they're getting there.
But
So
based on your model?
Not based on mine particularly, but a pathway. And,
okay.
Perhaps, we'll wait and see what it's like, but something that is useful for nurses to use, and will direct them to the problem, the cause of the problem.
You've paved the way, and that's a good thing. So I'll go on to another question. This is the Colley model used across the board in most NHS trusts? And then it says, has anyone got any experience of implementing it? But I guess that second part was for anyone else who was involved in the conversation in the chat. So from I guess to the two of you, how widely used is the Colley model within the NHS?
Do you want to start, Sharon?
Sharon, yeah.
Well, for us locally, it's very embryonic. It's because Wendy has, with a group of clinical specialists, have developed the current model. So now it's out how to embed that into current practice. So that's what I'm working on locally. Where my other colleagues are across the country, I'm not sure.
Yes,
okay. Wendy, do you have any idea?
I don't know how many, but I do know we have had inquiries as to how can it be incorporated into the EMIS system, okay. Which, these IT systems, all the trusts tend to use different ones. So we are trying to look at that, but if anybody has any, is able to help, it would be very well, they'd be, be very happy for them to join us to try and work out how it could best be implemented in that way, in the EMIS system.
Okay, well, maybe we've got... Go on, Sharon.
Sorry, Alec. I just wanted to pick up, Wendy's raised a very good point. In the NHS, we are using a variety of different platforms in order to collect our data, to share information, etc. So I think for what I'm doing is using a hyperlink system. So it's actually, you can link into the model website. So of course, all the different platforms that are available across the NHS may need a different way of connecting up. So I think that would be unique to the individual systems that are used.
Okay, thank you very much. A question, I guess, there's a couple of questions left. The next one is, how long does it take to complete an assessment using the model?
Well,
Sharon, do you want to start with that?
Wendy, over to you, because I'm still new to it as well.
It depends really on the assessor and the patient. For example, it's talking about reviewing any functional problems before you start. I had an example recently of somebody who was discharged from hospital, not incontinent when they went in, but they came out with the label of incontinent. And it was somebody with a degree of learning disabilities who was usually asked if he needed the loo, and he would say yes or no and be guided to the loo or go himself. And I think possibly he just spent 5 weeks in hospital, and I think possibly hadn't been toileted. And really, I think having got back to the care setting, if he'd been asked again and regularly asked to go to the loo, then he would have, he wouldn't be incontinent as he was labelled when he came out. Do that first, do the easy bits first. I'm not saying that, reassessment is a very important thing as well. You may need to reassess as you go on, but it depends. I can't really say how long it takes because it depends on the assessor and the skills and the individual patient. Yeah,
the individual patient, the individual circumstances. I was told, I remember, I can't exactly remember where, but a couple of years ago, I remember saying the term incontinence and somebody telling me that we don't use that term anymore. We just say continent or continence was the issue. Have you come across that, or was this somebody just being belligerent?
I think it does raise issues around terminology. Incontinence is a term, so it is a recognised term. However, what we have to remember is the lay public may have different connotations of that. So it's really important that we get our communication right within our clinical assessment. So, for example, for me, I would not ask my patient, are you incontinent? I would ask something like, are you bothered by your bladder or your bowel? Does it let you down? Or I'd use terms that probably resonate with them more so than the word incontinence, because I've had people say to me, I'm not incontinent, but I have leaks.
Yeah.
So it is one of the same in terms of definition. If we classify that through our history taking. So I can understand, we use the word incontinence, but it's important that we actually adjust our questions to be sensitive, so that we can get the best information, because it will mean different things to different people.
Brilliant.
Yeah.
Thank you, Sharon. Sharon, Wendy, our time is over. I'm sure that you'd continue talking with me for the next hour, but we need to let our audience go and get their dinner, get a glass of wine or something stronger. Thank you very much to the audience, for every one of you who have joined us this evening. We do really genuinely appreciate your time. There will be some links on the on the screen at the moment for how to download your certificate. There's still loads of questions that are coming through. So as I said earlier, we will get to those and we'll create a PDF which we'll put onto our website alongside a copy of the presentation and the slides. Wendy, Sharon, great job. Thank you very much for joining us. And I'd like to thank again the, you said AHPMA earlier? AHPMA. I've always just said the actual letters, the AHPMA. So or AHPMA. So thank you to those as well. Thank you very much. I know they're busy in the background actually sorting out the questions. So thank you very much for giving up your time this evening. And thank you for everybody that supports that organisation. Thank you to my team. Good night. We'll be back. Just one thing, if you're still with us, the UCCT will be having our first event in June this year. So keep an eye out on our website and you'll be able to find some information out about that. It'll be a free event for you to come along to. So we'd love to see you there, where maybe you can meet Wendy and Sharon in person and ask your own questions directly about the Colley model. Good night. God bless. And we look forward to seeing you soon. Goodbye.
Thank you, Alec. Thank you.
Thank you.